Thank you, Peter, for the great talk. I would like to invite the panelists to the stage. We'll also shortly introduce them. We have Cynthia Beckman. She's Director of Development at the Celiac Disease Center in New York. She's been involved there for over 20 years, and she's been a great help together with Peter and the whole team to establish the Celiac Center in Zurich. Studerus, she opened the center together with me in Zurich, and she's our nutritional expert for celiac disease and IBD and all abdominal issues and diseases, and we're really happy to have her. And Stephan Vavricka, everybody in the room knows him. He's been a long year a friend and colleague of mine. We've been working together since day one I arrived in Zurich. We shared the office since at the University Hospital, and we're doing a lot of work for the celiac community in Switzerland. We're in the steering committee of the Swiss Celiac Patient Foundation, and hoping to do a lot more the next few years. And I'm also really happy to have Raoul Furlano here. He's a pediatric gastroenterologist from the University Hospital in Basel. We also have a collaboration together, and he's my #1 expert if I have questions to pediatric celiac patients, and I'm looking forward to our discussion. May I start maybe with a question for you, Peter?
Sure, I'll just make a comment. So it's tremendously admirable in starting a celiac center, and the only credibility, I think, is the quality of the dietitian. You know, you can't, like, it's easy for the physicians to know what to do, but the quality of the dietitian really determines whether the celiac center is going to be successful.
Thank you,
So
Peter.
you're very lucky.
Thank you.
Maybe I'll start with a question for Peter. When we see the outcome of celiac patients on the gluten-free diet, it's very good. And if we compare that to possible medications that will be available in the future, that would mean maybe for a child getting diagnosed, having a 60, 70-year-long medication intake. Are the risks maybe higher with the side effects of the medication than being on the gluten-free diet, do you think?
Yes, like we've all had experience of people taking pancreatic supplements and getting terrible allergic reaction. So, you know, there is a price to pay for this therapy that will be developed, and yeah, because the therapy is a diet that is generally safe, it's a very big hurdle. And like, as you know, these therapies, the therapy tried to get approved is like 3 months or 6 months of taking a pill. So I think there's very great concern for, you know, like the kid who could have been on a gluten-free diet and has a death related to a terrible allergic reaction or something to an enzyme. Like, I think the enzymes will be the first on the market, which is appropriate, and it's going to help with the diet. But then, you know, the biologicals, all the companies that have biologicals on the shelf are looking at them to apply to celiac disease. And that anti-IL-15 therapy for refractory celiac disease, type 2, very big study, very rare condition. We could only find 2 patients in the United States with it to enroll in the study. You know, so there are exciting therapies going to be available, but the risks, I think, are great. What do you think? Your patients want it? Are you going to be prescribing pills for the kids?
The parents would like that, but I don't think the kids. So as you showed in your slide, you know, I think that's the thing. I'm a bit careful with biologics and stuff like that, because we know it from the EOE, the eosinophilic esophagitis, where, for example, in England, there was a case, and it was quite dramatic. It was treated with biologics, and they had a death about that. But this was single case, anecdotal. But since then, the community in pediatrics is very, very restricted in biologics for not IBD patients. So when it comes up, we will be very much in need of good studies before applying this biologics to kids, I think. So, yeah. And the therapy, the gluten-free diet, as you know, is a fancy diet. In America, I don't know how many billions. The advantage is spent for this diet. The advantage of that fancy thing and glimmer and celebrities who do that, and it's really silly. The advantage is that we have much more quantities and less expensive food on the market now, and globalized stores have these diets. Beforehand we could only have in specialized shops. So this is an advantage of that. In Switzerland we just finished, and then I stop, we just finished a study in 2,500 kids just to see are we fancy as well here in Switzerland, or are only the Americans fancy, I don't know. We did 2,500 kids and looked if they do a certain diet, just out of the nothing. And surprisingly, we had 16% of these 2,500 kids followed a strict diet, any, gluten-free, carb-free, whatever. And in more than 60%, there was no diagnosis behind that. So imagine this thinking about that. This is important when we treat with diets, because you talked a lot about that. Yeah. Thank you.
And on the other hand, a lot of patients tell us that they don't want a diet because they feel good if they are ingesting gluten. So what do you do with those patients, your daily clinical practice?
So, definitely many patients are satisfied with a gluten-free diet, We try to encourage them to follow with the dietitian to make sure their diet is healthy, but that's great. That's great if they like that diet and it's not too socially inconvenient for them. It's fine. Now, some of those individuals are not on a very good diet. Not on it because they'll still have villus atrophy. So if we find villus atrophy in an individual, we'll send them back to the dietitian. And so currently we have available now in the United States the gluten detection for the stool. It's available through the commercial labs. So for those individuals, we might use that to show them that they're actually ingesting gluten, because you come back with a number. And so the gentleman that you presented, it's an interesting case because his villus atrophy is resolved.
He's good.
But he still has a positive antibody.
If you look at the labs, it's good.
Yeah. And like an abnormal tissue transglutaminase should predict the presence of villus atrophy. So like that doesn't really match. It'd be interesting to get, so it's wonderful. He's we did studies showing that people who had persistent villus atrophy had increased risk of lymphoma. There was no increased mortality. There was no increased cardiac events. There was increased risk of osteoporotic fractures and increased risk of lymphoma in people with persistent villus atrophy. So did you, so he's done well in that respect.
Yeah.
May I make a note? But this is true only for people over 40 and in the first year of the diagnosis. Is that correct? If I interpreted the results correctly, because that's not true in children. So in young.
I question that because I think that there are very few studies now that have done follow-up biopsies in children, and there are some studies that do show persistent villus atrophy. And now, if you're not biopsying people to diagnose it, you're never going to biopsy people to see if they've healed. So I don't know that old data about children always normalizing really holds true.
The Swedish colleagues published in July, the last one, where they calmed down, because for us it's difficult to tell to a 4-year-old and their parents say, you know, the risk of lymphoma is high, because they ask. They know that. They go to Google it and find this lymphoma thing. So I would be a bit careful before.
Oh yeah, it's
before
very hard to tell. The risk is not that high.
Careful, yeah.
It's very hard to use that as a reason to stick with a gluten-free diet.
Yeah.
Because the chance of getting a malignancy is low.
Yeah.
And when Peter said the nutritionist is the most important person, how would a potential treatment change your counseling, or who's the perfect patient for you for the treatment?
So to be honest, every patient is asking me about medication and other treatments. So it's one of the major questions in my consultation. And I think, and respect to your talk, I think what you said is perfectly correct, because it's not a replacement of diet, and that is always what people are wanting to hear from me. So there is a pill and you can eat whatever you want, and that's not true. And I think patients with a good adherence, and as our example from the soccer player was, he's really adherent, he is checking for cross-contamination, he's really want to have a good gluten-free diet, but he's eating outside, he has some lunches, not knowing what will be cooked and how it's cooked. And I think that's a good example for a potential medication, because there is that little risk which you can't control as a patient, and therefore we need the medication, but not to replace or to be able to have a slice of pizza or have a croissant.
Well, he's a good example of, like, I'll say to an individual, like, you live in New York, you eat out all the time, it's very good for you to get a biopsy, because if it's normal, you can't do any better. Like,
totally
he can't
agree.
do any better. He can't be very normal.
And that's totally my approach. When a biopsy is good, I know the diet is good, and I won't change anything, especially if they have once a month gluten. Intentionally, I will allow them when the biopsy is good, because quality of life also matters, and not just the histology.
Yeah.
I agree, but on the other hand, we know from studies from 20 years after healed celiac under gluten-free. I call it healed because on the gluten-free, we have a normal villi, we have everything normal. And we know from John Walker Smith did that 20 years later, and transglutaminase was negative. But when he biopsied 20 years later, he saw villous atrophy. So chameleon, again, celiac. Makubaki says the more I study on celiac, the less I understand. You know.
But Raoul, I think, there is atrophy, but do they have symptoms? Do they feel something? And we know we only have 2 diagnosed out of 10. There are 8 running around with celiac disease not knowing what they're having. They have atrophy, but they don't have...
atrophy means inflammation. Do you want chronic inflammation as in IBD?
Yeah, but
no.
we don't see that much of lymphoma carcinoma.
Well,
so
that's an interesting point, because,
tension.
like, in IBD, you treat to heal, don't you?
Sorry.
Like, we don't do that in celiac, please.
Yeah.
That's not the goal.
Bernhard?
You should go like that. Peter, actually I'm interested in, why do you think the prevalence of celiac disease is increasing because of what? Is it better diagnosis? Like you diagnose all those family members who never wanted to be diagnosed and they have no symptoms? Or is it the increase of the new, or the wheat that contains much more gluten than it used to?
Sure.
Or is it just the usual thing we see, Stephan, in IBD with the more autoimmune diseases? Is this hygiene hypothesis? Is it anything like going towards IBD type of thing? Because you call it an autoimmune disease.
Okay, so the data is that serum taken 50 years ago, it was this Warren Air Force Base cohort, which was 20-year-old white men going into the Korean War. They had 0.2% of them had positive TTG and endomysial antibody. And then, like Joe Murray did this, and then he took 20-year-old white men in Minnesota and 70-year-old white men in Minnesota, and it was 1%. So it had increased 4 to 5-fold over that time period, and the increase was shown to be in the 80s and the 90s. And the reason for that is not clear. It's not related to the amount of gluten in wheat, because that has not changed.
Yeah.
And actually in the United States, the amount of wheat consumed has gone down dramatically per individual compared to the 40s. So it's not the nature of gluten or the amount of gluten. The amount of gluten is questioned because they add this purified gluten to a lot of food. So that's not taken into account.
Yeah.
But the risk factors that we looked at with Jonas Ludvigsson in Sweden were antibiotic use, any infection, GI infection. There are several risk factors, but the reason for the increase worldwide is not known. But the increase is leveling off. Like studies in Finland shows that it's leveling off, and in the United States, the increase has decreased. So,
The food processing industry also.
Well, they add this microbial tissue transglutaminase to food. They add a lot of stuff to food that is just under the category of generally considered safe.
Yeah.
So, who knows? But it's not known what that increase was, but it's very well known that it occurred in the 80s and the 90s.
And I think in this topic we learn actually a lot from IBD, because we have those 2 exclusion diets which are working wonderfully, and they cut off all the additives basically. So you have to cook at home. Everything you eat you have to cook by yourself, and they are doing well without any steroids, without any medication, just with diet in a Crohn's disease. And now we have data for ulcerative colitis too. And that's amazing, I think. And I do see some parallels in those diseases, celiac and IBD. And I think that is promising for me, that we maybe get also a better understanding for prevention in the future.
Like H. pylori is protective for celiac disease. So everything seems to be related.
Okay, in the sake of time, I have to close the session. Thank you, Peter. Thank you for the panelists for the great discussion, and I'm looking forward to the next talk.
Thank you very much.
Thank you.